Hello there, this is Dr. Brian Buchanan bringing you this tutorial on detection of pericardial effusion in trauma as a component of the eFAST exam. We'll cover several learning outcomes, including developing a critical approach to detecting pericardial effusions on cardiac ultrasound, differentiating from potential confounders, and integrating your understanding of bedside physiology with the hemodynamic consequences of a significant pericardial effusion. Obviously, there are many elements to the eFAST exam. We're going to focus on the assessment of the pericardial space. This is likely a view you're most familiar with. This is a subcostal four-chamber view. To obtain this view, palpate the inferior edge of the sternum and place the probe directly below in the midline, with the probe marker facing towards patient's right. This generally requires you to depress the probe beneath the sternum and to tilt the tail of the probe more towards patient's abdomen, revealing the following image, with the liver seen in the near field, right ventricle, and left ventricle, and the surrounding pericardial space. This is a cartoon illustration just showing exactly where the anatomical plane is here and what exactly we're looking at. This is a cross-section across all four chambers, including the pericardium. Next, we're going to have a brief look at the parasternal lung axis view, a view which you may be able to use to detect a pericardial effusion in the absence of subcostal four-chamber view. This is with the probe marker facing 4 o'clock at the third or fourth intercostal space. We can see the right ventricle, left atrium, aortic valve, and aortic root. We often refer to potential effusions as pericardial separation, as an anechoic space has a differential and fairly defined echo characteristics. Not all separations are new or clinically significant, and a common confounder is epicardial fat, which we'll discuss. So also things like clot, pus, cyst, and malignancy. You are less likely to see these in setting of trauma, but may depend on where you practice. A common confounder in any view is the epicardial fat pad. This is a subcostal four-chamber view, and you can see here there is a space of kind of mixed densities between hypoechoic and more hyperechoic. This is fairly typical of an epicardial fat pad, which is more commonly found around the right ventricle surface. Here we can see a subcostal four-chamber view. This patient actually has a pericardial effusion, but also has a fat pad. And the pericardial effusion allows us to have some acoustic enhancement to show the epicardial fat pad in higher resolution. We can see here again it's quite dynamic and follows the right ventricle very closely with mixed echogenicities. Here we have a comparison of a subcostal four-chamber view. On the left, we see it's negative. There is no evidence of pericardial separation. On the right, we can see a large circumferential anechoic space bathing the entire cardiac silhouette. Here we have an example. This is a subcostal four-chamber view obtained from beneath the sternum with the probe marker facing the patient's right, and obviously the screen marker facing the left. We can see here the right ventricle, right atria, left atria, and a large surrounding anechoic space. Importantly, we see the right ventricle is very small and underfilled, which is likely a consequence of the large effusion. Next, we move to a parasternal lung axis view. Again, we see the left ventricle, left atrium, aortic valve, and aorta. Here we have the descending thoracic aorta, which is seen as a circular anechoic structure juxtaposed to the left atrium. Next, we see this wedge-shaped anechoic space. This wedge, which travels anterior to the descending thoracic aorta, is a pericardial effusion. This further confirms our suspicion that this is indeed a pericardial effusion. Pleural effusions are often a source of diagnostic confusion. There is a high prevalence in critically ill patients, and in fact, there's a high prevalence of trivial effusions amongst the normal population. And both pleural effusions and pericardial effusions can be important, as both may be clinically relevant in the patient with trauma. We can see here on a parasternal lung axis view, on image left, we have a pericardial effusion. Again, this is a wedge shape that travels anterior to the descending thoracic aorta. On image right, we see a fairly blunt shape to this anechoic space, and it's traveling around the descending thoracic aorta. This is very typical for a pleural effusion. If you look closely, you can see a small sliver of a pericardial effusion of minimal significance. If there is any confusion with respect to the presence of a pleural effusion, we can also look in the left mid-axillary line for the presence of an anechoic space above the diaphragm. Tips and tricks. The more you look for effusions, the more you tend to find them. Again, there's a high prevalence of trivial pericardial effusions amongst the normal population, and it's important not to be distracted by these trivial effusions. The clinical history is important, as patients with chronic illness such as chronic kidney disease or hypothyroidism may have asymptomatic or occult pericardial effusions that occur prior to trauma. It is difficult to say whether these effusions are truly acute relating to traumatic illness, but should likely be treated on that suspicion. Furthermore, comprehensive echo is likely required regardless, as patients with blunt penetrating chest trauma may have other abnormalities such as regional wall motion abnormalities and valvular abnormalities, and structural abnormalities like aortic tears. So it really requires the clinical context for interpretation. Patients with blunt penetrating chest trauma, sternal fractures, hemodynamic instability, and unexplained persistent shock out of proportion to injuries are likely the highest risk of injury to the cardiac structures and resultant pericardial effusion. If you are significantly concerned, then I would suggest you involve your colleagues in cardiology sooner rather than later to help weigh in. Just like other segments of the eFAST examination, you can improve sensitivity by performing the scan more than once, and furthermore after evacuation of a hemothorax. Pericardial effusions in severe chest trauma may occur secondary to aortic dissection, hence the importance of involving early consultation and further imaging such as CT. Cardiac rupture with tamponade is the most devastating blunt cardiac injury. In this case, most of these patients don't even make it to the emergency room, never mind from the scene. And if you suspect pericardial tamponade, then just give fluids or blood. It can buy time until surgical management. There is ever-present risk of distraction with using echo to look for pericardial effusions. The important part to realize is that a patient with tachycardia should first be attributed to significant hemorrhage. Finally, it's often difficult to tell whether or not a patient has a hemodynamically significant pericardial effusion. Back to this case we saw earlier, we often look for RV collapse in early diastole. In this case, we see the RV is dynamically collapsing. This increases our suspicion a great deal that there is obstructive physiology, as this chamber is more likely to collapse in the setting of a large pericardial effusion. Furthermore, a patient is more likely to develop tamponade in the setting of massive blood volume loss and hypotension, further requiring aggressive fluid resuscitation. So in summary, we talked about image acquisition, subcostal 4-chamber view and the Parasternal long axis view. We talked about detection of pericardial effusions and pericardial separation. We talked about differentiating pleural and pericardial effusions, also looking at epicardial fat, which may be a confounder. Finally, we looked at hemodynamic consequences of pericardial effusion, such as dynamic RV collapse. I'd like to thank you for listening to this talk. Bye for now.